So today I'm really going to talk about the impact of aging physiology, how it relates to when you are managing older patients in the emergency room setting. So our objectives are that I will review the impact of aging on, physiologic processes, which are actually quite important when you're dealing with patients in the emergency room setting. Describe the concept of homeostenosis, and some of you may have heard me talking about that before. And then really talk about the significance of age-related physiologic changes on clinical presentation and management of older patients in the emergency department. I think all of you would agree that aging is not a simple process. I think people are trying to figure out what aging process is. So it's pretty complicated. We know that it's inevitable and extremely complex multifactorial process. It's characterized by progressive degeneration of organs and tissues and largely determined by genetics, but really influenced by a wide variety of environmental factors. And I think you all know, diet, exercise, lifestyle, what we have, it does influence the aging process. So if we think about physiologic changes, I think we can kind of group them in three areas. One is that there are changes in the cellular homeostatic mechanisms, and I'll be talking about that in terms of blood pressure regulation or volume regulation or temperature regulation. We know that there is decrease in organ mass, and I think the most significant one, which I just like to convey that concept to you, is that there is decline in and loss of functional reserve of the body system. That older people may be able to function quite well under normal circumstances, but it's when the stress occurs, and I'm sure that you see patients in the emergency room who are very sick, that's the time that they actually run into a problem. So I think this is really depicted well here, that if you have a younger person, because there's a lot of redundancy in our physiologic processes. So when you have a younger person, there is plenty of physiologic reserve available. So if they are stressed, they are able to handle that. But even without comorbidities, just with primary aging, that there is actually erosion of this physiologic reserve. So you can see that as people get older, even when they don't have comorbidities, that their actually physiologic reserve goes down. And then on top of that, we know that chronic diseases are very common in older people, especially when they get frail. They are already tapping on their physiologic reserves, even with their day-to-day activities. So when they come to the emergency room with an additional illness, you can see that they are just right over the cliff here, and they can really fall off the cliff, and then you can run into a lot of problems. And I'm sure that you come across that in frail older patients, that they actually are very prone to develop complications of hospitalization and do have higher mortality. So in the past, we actually have thought of aging physiology more as like a reduction, like a linear reduction in the function of these physiologic processes. And you can see that we know that there are changes in fasting blood sugar, you have changes in the nerve conduction velocity. So there is kind of linear decline of several physiologic processes. But I think we have actually started to look at aging in a little bit different way now, because this concept was actually put forward in the 90s, that the aging is really a loss of complexity. And by that I mean is that we know that there are a lot of the physiological systems actually are interconnected. So there are a lot of complicated outputs which are actually sent by these physiologic systems, and you can see that the output signals are actually very complex. But as people get older, these connections between the different systems or how they are regulated, that actually changes, or that actually deteriorates, and these signals become less complex. And when people become frail, they actually have even more problem with the connecting systems, and that actually results in frailty. So this concept actually has, we have started to look at it more, because if you look at the effect of age on heart rate variability, and that's not something we think in clinical practice that it is significant. You're not checking people's heart rate, that how variable it is, but if you think about it, that there is certain reason that why the heart rate is variable. So if you compare that with younger individuals compared to older individuals, you can see that the complexity or the heart rate variability actually goes down as people get older. Now this is multifactorial. Some of the reasons are that there is dropout of sinus node cells, you have altered beta adrenergic receptor responsiveness, and an apparent reduction in the parasympathetic tone. So there are many reasons that why this can happen. So there was actually a study published a few years ago, and they wanted to take a look at it, that what is the relationship of this physiologic complexity which we have underlying heart rate dynamics and frailty status in community dwelling older women. So their conclusion was that there is some connection between this heart rate variability and frailty, that actually people who are more frail, they have less heart rate variability, or they have less complexity of that. So what that tells us is that there are a lot of physiological systems and connections that we actually don't understand in our day-to-day practice, but the older people have less complexity of these systems. That's why they don't have that much redundancy, and when additional stress occurs, that they have difficulty coping with those stresses. And I think you come across that a lot in the emergency medicine setting. The other study actually looked at that, what is the relationship of physiologic complexity and aging in terms of implications for physical function and rehab. So they had people stand on this forced plate, and they were standing with their eyes open, and they were looking at what the postural sway is, and that is really the center of pressure change. And they actually noted that this complexity index is higher in healthy younger adults, less in healthy older adults. And on top of that, when people have, for example, peripheral neuropathy, the stroke patients, you can see that this complexity actually gets down, that the systems actually become less complex. So I mean, it's I think it's understandable when people get these illnesses that complexity goes down, but even in older individuals who are relatively healthy, that the complexity index goes down. So I think just a little different way of looking at aging physiology. Now we also do know that in addition to these changes in the functional systems, that you actually have changes which occur in the structure or the anatomic structure of when people get older, and we know this, that the neurons, that they have less loss of branches and neural connections, that the synapses are not that much as they are in healthy younger individuals. We all know that there is actually evidence of problems with the bone structure, that everybody ends up developing osteoporosis, even males, though we know that it's much more common in women because of withdrawal of estrogens. There are issues with the kidney in terms of, if you look at the glomerular capillary tuft, there is degeneration and loss of capillaries. In the skin, there is issues with the elastic fibers and dermal papillae, and you can see that there is loss and collapse of subepidermal structures, that we don't have those ridges between the dermis and the epidermis. So we know that there are some structural changes which occur with aging, but also the physiologic systems actually become much less complex. And this slide shows that difference between a normal bone and osteoporotic bone. So you can see how the trabeculae are different. There's not that many connections as people get older. So I just want to spend a little time about aging and blood pressure regulation, because there are changes which occur how a body actually regulates blood pressure as we get older. We know that the baroreflex mechanism actually plays a very important role in terms of regulation of blood pressure. When there is transient decrease in blood pressure, there is the baroreceptors which are actually present in the carotid area and also in the aortic arch. There is less firing of those baroreceptors. So that means that the parasympathetic tone actually goes down and the sympathetic outflow increases. So that means that the heart rate actually goes up and your vascular resistance goes up in order to compensate for that transient lowering of the blood pressure. And those opposite effects occur when you have actually rise in blood pressure, because the baroreceptors actually get stretched and there is actually more firing of those baroreceptors. So older people do have a problem with baroreflex response to arterial pressure changes. It progressively declines with aging. That means that the older people cannot adjust to these changes. For example, that's the reason that why they have more prone to develop orthostatic hypotension. Now the other change is generally when the pressure goes down, the heart rate accelerates. But that is another problem which we see as people get older, that there is reduced adrenergic responsiveness by the aged heart. So that diminishes baroreflex mediated cardio acceleration in response to hypotension. In addition to that, we also know that the cerebral blood flow decreases by about 20%, and cerebral autoregulation process, and this is the process how actually the brain can regulate the blood flowing, also is impaired in chronic hypertension. So I think the clinical significance or the clinical impact of these changes is that a lot of time you will see patients in the emergency room setting, who come with syncope. And most often they are multifactorial, because when you're checking different systems, what is contributing to syncope, in majority of the patients you actually don't find out the cause, that why an older person is passing out. So some of it is related to the altered physiologic mechanism, some of it is also related to the medications we gave. So it's a combination of events which actually makes an older person more prone to develop dizziness and syncope. And that's a very common complaint. I'm sure that you see that in the emergency room. A lot of people come, well, I'm feeling dizzy, and when you test several, whatever common tests that we ordered, and most of the tests actually come out to be normal. So it is really multifactorial, physiologic changes, as well as some of the medications that we are giving to them, and also some of the comorbidities that they have. Because when people have hypertension, they do have more problem with cerebral autoregulation as compared to individuals who don't have hypertension. So it's a combination of changes which actually results in patients complaining of dizziness and also even passing out. We know that there is a condition called postprandial hypotension, that after a big meal, after about half an hour, older people can have actually drop in their blood pressure. And if you are giving medications, for example, nitrates, which are vasodilators, that can also contribute towards hypotension. So some people can pass out after meals. There's also, as I said, that increased risk of orthostatic hypotension, especially with medications like nitrates, diuretics, and antihypertensive medications. So older people are just more prone to develop these complaints of dizziness as well as syncope. So let's spend a little time about volume regulation, that what happens to older people in terms of regulating their intravascular volume. So you have a patient on the left side, which is a 25-year-old, fluid deprivation for 72 hours, no change in sodium, no change in BUN, no change in serum creatinine, and has mild hypotension with sinus tachycardia of 130. But the response in older individual is much different as compared to younger patients. Here's an 80-year-old, just fluid deprivation for 24 hours, NPO, just made NPO. They didn't order IV fluids, and you can see that the patient actually has developed hypernatremia. Their BUN has gone run high, even though there is no creatinine change. And in terms of cardiovascular changes, patient has some hypotension and not that much sinus tachycardia. The heart rate is only about 100. So why older people are actually more prone to develop dehydration, especially hypernatremic dehydration. So I mean, one thing I would say that, you get a lot of patients from the nursing home which come to the emergency room, and sometimes patients, it's not the neglect in the nursing homes, because sometimes that you may get that impression that, well, why people are coming to the emergency room, they are dehydrated, maybe they are not being taken care of properly, maybe they are not being given fluids in a timely manner. But the fact is that, older person can have just minor problem. They could have a sore throat, or they have loss of appetite for some reason, and they can get dehydrated in a matter of 24 hours. So you could have patients coming to the emergency room which are hypernatremic. And sometimes I do hear from the nursing homes, because they say, well, the ER physician told the family that, oh, your loved one was not being taken care of in the nursing home setting because they were not provided with enough fluid. So I think we just have to be careful as to what we say to families, because sometimes they can misinterpret that. I mean, the fact of the matter is that it does not take that long for a nursing home resident to get dehydrated. So I mean, in terms of them developing hypernatremia and having intravascular volume depletion. So and the many reasons for that. I mean, one, we know that the body water as a percentage of total body weight actually does decrease as a consequence of aging. With the younger person, about 60% of your body weight is related to water, whereas there is increase in fat as we get older. So the total body water as a percentage of total body weight does actually decrease with aging. In addition, we know that there is decreased thirst drive, decreased ADH response to hypovolemia. There is decreased maximum urinary concentration. So even when people are not taking enough fluids, the kidneys do not have the ability to concentrate urine as much as they would do with a younger person. And then some other reasons in terms of that, people who have dementia, they are confused, they may have difficulty having access to water. Even if you put the water by their side, that they may not be able to have or drink it because of physical or cognitive disorders. So there are many reasons that why actually older people become dehydrated very quickly, and you see that hypernatremic dehydration is much more common in older individuals as compared to younger individuals. And the opposite is true for when we are giving excessive fluids to older individuals, because you can then precipitate hyponatremia as well as congestive heart failure, because there is decreased ability to excrete free water load, leading to hyponatremia and fluid overload in older patients. So we have to be careful when we are managing or giving IV fluids to older individuals. Just a couple of words about aging and thermoregulation. We know that the temperature regulation also gets affected as we get older. So older individuals are more prone to have hypothermia and heat stroke. I'm sure that you come across these patients in the emergency room setting. So two things to remember about hypothermia, that what happens with aging. One is that the older people don't shiver and they don't vasoconstrict, because shivering actually has increased muscle activity, so you increase the production of the heat, and then the vasoconstriction actually helps you to conserve heat. So the problem with older people is that they don't vasoconstrict and they don't shiver that much. And other things which can contribute towards hypothermia is that there is delayed perception of being cold, and also there is reduced meal-induced thermogenesis. And the opposite is true for when you have hyperthermia, or older people are more prone to have heat stroke. When the temperature goes high, I'm sure you hear on the radio the making sure that the older people have air conditioning, they are drinking enough fluids, because they have more propensity to develop heat stroke. And the reason for that is that they do have decreased thirst. They don't vasodilate, that to get rid of the heat, and there is increased threshold temperature to initiate sweating. So they are not sweating that much. We know that there is also reduced output of the sweat glands. And there are many drugs which we give to patients which actually interfere with these mechanisms. For example, when we give them anticholinergic medications, that's going to cause hypohidrosis. Diuretics actually cause hypovolemia. And the beta blockers result in impaired cardiovascular responsiveness. So all these factors in physiologic changes as well as the medications that we are giving to older patients actually increases their risk for having hyperthermia or stroke. Also, I think this is something I'm sure you are aware of, is that fever response in the elderly is quite different as compared to younger individuals. The ability to raise body temperature in response to pyrogens is blunted with age, and about 25% of the older persons with sepsis actually do not have fever. So, the absence of fever doesn't mean that the person doesn't have infection, because they are not able to mount that fever response. The next is just want to spend some time about talking about the cardiovascular system and how actually it impacts when you're taking care of patients in the emergency room setting. So I would say that I think the things to remember about the cardiovascular system is that your arteries actually become stiff and the heart pump becomes stiffer. And that there is problem with the conduction system, as people get older. So what I mean by that is that we know that there is decreased compliance of the arterial tree. So it increases afterload on the left ventricle, and it's not uncommon to see some left ventricular hypertrophy in older individuals. Many individuals do have a increase in systolic and pulse pressure. I mean, even though that's not a normal part of aging process, but many systolic hypertension is much more common in older individuals. We know that there are some structural changes occur in the myocardium, that there is myocardial cell hypertrophy, which leads to slowing of the ventricular relaxation. So the left ventricle actually becomes much stiffer and takes much longer to dilate as compared to younger individuals. I already mentioned about decreased responsiveness to beta adrenergic stimulation. Even though we know that older people, the catecholamine levels actually are higher in older individuals as compared to younger individuals, but the heart really does not respond to that catecholamines, and there is decrease in beta adrenergic responsiveness. There is fibrosis and calcification of the conduction system, and we see that older people are a lot more prone to have heart blocks. Atrial fibrillation is a very common arrhythmia which we see in older patients. So in terms of what happens with the stiffness of the heart and what impact that has on an older person in terms of their cardiac function. So if you look at the younger individual, with the red line, that you can see that most of the diastolic filling actually occurs in early diastole, because the heart is able to relax and you can have the ventricular filling. But as the heart gets stiffer, and you can see in an older person, the most of the diastolic filling actually is occurring in the later stage of diastole. So why that is important is because the later filling in the late diastolic period actually is potentiated by the atrial kick which occurs. So you have more blood actually coming to the left ventricle, and that becomes very significant, because when you have patients with atrial fibrillation, they actually lose that atrial kick. So it's much more common that the older people with atrial fibrillation can go into congestive heart failure. So some of the clinical, in terms of cardiovascular physiology, we know that there is decrease in maximum heart rate. There's not much change in terms of basal heart rate or heart rate at rest. But the maximum heart rate does decrease as we get older. There is decrease in maximal cardiac output with exercise, that we know that the heart is not able to mount the increased heart rate, though at rest, under ordinary circumstances, the heart does compensate for that because the stroke volume actually increases. But with exercise, there is decrease in maximum cardiac output. There is decrease in maximal aerobic capacity. There is decrease in cardiovascular reserve. So there is decreased threshold for an older person to develop congestive heart failure and atrial fibrillation. So some of the clinical implications, as I mentioned, that systolic hypertension is much more common as people get older, and systolic hypertension and widened pulse pressure are risk factors for stroke, renal failure, and heart disease. Age is the strongest predictor of mortality following acute myocardial infarction, and we know that there is atypical presentation of myocardial infarction in the elderly, but 1/3 of the patients actually do not present to the emergency room with chest pain. That they may have shortness of breath or confusion, so they don't have typical presentation of acute myocardial infarction. I mentioned about the changes which occur actually in terms of stiffness of the heart. So you can see that diastolic heart failure, where the ejection fraction is normal, accounts for as many as 50% of the congestive heart failure patients over the age of 65. So not the systolic heart failure, which also occurs, but diastolic heart failure actually is much more common. And atrial fibrillation becomes more of a physiologic burden to the old heart because of age-related slowing of diastolic filling due to left ventricular stiffness and greater dependence for adequate filling on atrial contraction. So next is pulmonary system, as to what are some of the changes which occur. We know that there is reduction in lung compliance, which causes the airways to close actually at higher volumes. In older people, it's not uncommon to see that they at the age 75 or 80 that their PaO2 is around 75. So there is reduction in the partial pressure of oxygen in the blood, and that is primarily related to mismatch of ventilation and perfusion in the dependent portions of the lungs, because in the dependent portion of the lung, the airways close, but the blood is still circulating, so there is ventilation perfusion mismatch. And you can roughly calculate the PaO2 by the formula. I have it here. In addition to that we also know that chemosensitivity to oxygen and carbon dioxide tension declines, that there is relative hypoventilation when your PCO2 goes up, or there is hypoxia. So the older people don't respond as well in terms of increasing their respiratory rate as younger individuals would do in terms of when people develop hypoxia, and especially hypercarbia, that they don't have increase in their respiratory rate. We know that with aging, there is actually linear decrease in vital capacity. As people get older, your total lung capacity remains the same because there is actually increase in residual volume as patients get older. So what are some of the clinical implications of the changes that I described? That there is higher risk for developing respiratory failure in response of an acute illness, and we know that sometimes the pathology doesn't have to be in the lungs. I mean, people can develop respiratory failure because of other systemic illnesses. And also, just to make sure that the complaint of dyspnea must be taken seriously, because compared with younger adults, older adults may not develop this symptom until they are at a later stage of their illness. So I mean, this thing is, we always keep in mind when we are getting calls from the nursing homes, for example, that in terms of us figuring it out, well, do they have just upper respiratory tract infection or they have lower respiratory tract infection? I think when the nurses say that the patient actually is having complaining of shortness of breath, then you have to take it much more seriously as compared to somebody we think may have respiratory infection but is not complaining of shortness of breath. And older people, as we know, that have much higher mortality when they actually develop pneumonia. In fact, 5 to 10-fold increased risk of pneumonia as compared to younger adults, and they are much more likely to die from that disease. Next, renal system, just some of the important changes that we know that there is a general decline in the GFR as people get older. We already talked about that there is progressive decline in the ability to excrete a concentrated or dilute urine. So delayed or slowed response to sodium deprivation or sodium load. We know that there are decreased level of renin and aldosterone and increased dependence on renal prostaglandins to maintain perfusion. So that's why you'll see when we start people on NSAIDs, their BUN starts to rise because you are really depending on prostaglandins to maintain that renal perfusion. So when you actually block that, less blood flow to the kidneys, and you are going to have rise in the BUN. And also, there is decreased vitamin D activation by the kidney when it gets older. I think all of you know that we can't just depend on the serum creatinine values. They are not reliable estimates of renal function. We used to actually calculate creatinine clearance, but now all the lab reports actually show you what the creatinine clearance is or what the GFR is. They use the formula to actually calculate what the GFR, so you have a relatively good idea as to where the patient's renal function is. So that means that we need to avoid nephrotoxic drugs and the use of drugs that inhibit the renin, angiotensin, aldosterone system, such as ACE inhibitors or ARBs. They can actually contribute to hyperkalemia in older adults. And we also know that acute renal failure can occur very quickly and a lot higher mortality in older individuals. Just a word about the immune system, because I think you do come across people who are coming to the emergency room with a lot of infections. So what happens with our immune system in terms of our ability to cope with some of the infectious processes that older people can experience. We know that the efficiency of immune system does decline with age, and again it is related to those breakdown of those connections or breakdown of those pathways. Number of circulating B and T cells actually does not change with aging, but we know that the response of the T cells, their ability to respond to any antigenic challenge, is greatly reduced. And even though the number of B cells remains same, but the production of antibodies does decrease because they are not as responsive, and that is really from the effect of T cells. That what happens with them, that there's a reduction in the helper T cells and increased activity of suppressor T cells, even though the number of T cells does not change. So what are some of the the clinical implications? I think all of us know that there is increase in, when you do lab tests, there is increase evidence of having autoantibodies, that a lot of time older people actually have. The rheumatoid factor is positive, ANA is positive, they may have false positive test, for example, for syphilis. Also we know that there is elevation of monoclonal immunoglobulin. Sometimes it's asymptomatic, but we also know that multiple myeloma is a lot more common in older individuals. So I think just to keep in mind, the fact is that the common infections are often more severe with slower recovery and decreased chances of developing adequate immunity, because the immune system is just not as efficient as it is in a younger person. I just want to lastly just talk a little bit about aging and memory, because I think there's always like confusion related to, okay, well, is memory loss really a normal part of aging process? A lot of time our tendencies, a person is not oriented, or they are confused, they're confused because they are old. So just to give you a little idea about actually what happens with memory as we get older. I experience that the these, sometimes I don't remember somebody's name, or I mean, it will later on come back to me, but at that time, I don't remember that. So just some general idea as to what happens with memory. Okay, now, brain is a huge storage system in terms of, some actually the technology people have tried to estimate the capacity of the brain storage. And some people say that it's actually about 2.5 petabytes, and 1 petabyte actually is 1 million gigabytes. So the brain has a huge storage capacity, and that is really related to, because there are about 1 billion neurons in the brain, and then they all have synapses or connections. So the brain can actually store a lot of memory. And if you just think about, when we think about our memory, most of the time we think about long-term memory. So there is 2 types of memory. One is the procedural or the implicit memory, and the other one, if you think about long-term memories, 2 types. One is the procedural memory, and the other one is like a declarative memory. So the procedural memory is really related to the skills and procedures that, this is right. Well, how do you do things? If you like learning how you ride a bicycle. I mean, even if you don't ride the bicycle for many years, you go back and ride the bicycle, you are able to do that. So this is a memory which actually does not change that much with aging. I mean, I drive to the office, so used to driving there, I don't even have to think about that, where I'm going. So I think these are the how-to memories, that how do you do the procedures, and that memory actually remains the same as we get older. Now, the other type of memory actually is divided into, or the explicit memory is 2 types. One is semantic memory, which is the factual knowledge independent of time and place. This is something like the facts that we have learned, some of the medical knowledge that we have, so that you are able to retain that. And then the other memory is the episodic memory, which is really related to what, where, and when. That and this is the memory which actually fades somewhat with aging. Sometimes when this memory is easier to retain when there is some emotional things attached to that. The question is, okay, well, what day you went to school when you were 6 years old? I mean, that you went, but you may not remember the exact, like a day and time. But if there are some emotions attached to that, then we actually remember that. So this type of memory, the episodic memory, actually does fade as people get older, but the semantic knowledge actually kind of remains the same. Semantic knowledge, you can also think about is vocabulary that we have now. Vocabulary actually does improve as people get older. And then we have the short-term memory. Now, the short-term memory is, our ability, for example, you have initially there is sensory memory, whether it's you hear something or you see something or you touch something, that you form actually impression or sensory memory. And then that information has to be retained. They say that short-term memory actually holds very small amount of information, that only about 7 plus minus 2 numbers. And just think about it, a phone number, when you want to remember a phone number, I mean, somebody tells you a phone number, I mean, you can immediately forget that unless you do something to that phone number. Either you keep on saying it over and over again, rehearsing it, or have some association with that, otherwise you won't remember that. And so that type of memory, which actually manipulates that information in order to retain it, is called like working memory. Okay, so it's said that the short-term memory actually doesn't change. This is really the type of memory where you retain information for a very short period of time, only for about 20 seconds. As I said, you can have 7 plus minus 2 numbers that you can retain. Now, sometimes if you chunk that information, you may be able to retain. That's why the phone numbers are chunked, that you could maybe retain that information. So it's really the working memory which actually manipulates that information within the short-term memory to see, well, I'm going to retain that information. And this is that memory which actually gets affected in older individuals. So if we look at what changes occur with memory as people get older. So the memory involves really 3 processes. One is encoding, which is getting information into memory. Then it's storage, that we need to actually store that memory, that it goes in long-term memory. And then retrieval, that we getting information back out of memory when it's needed. So older people, actually, not that they lose memory, it's just the way the memory is processed is much different as compared to younger individuals. Retrieval processes become especially difficult. Encoding has some problem with encoding, but the storage is affected very little or not at all, with age. That once you're able to store the information, you are okay, but it's just the retrieval and encoding actually becomes different. So the other thing to keep in mind is that, and this is not something we talk about that much, is that what is the role of this prefrontal cortex? And I think we can think of brain as like a large corporation. You have a lot of inputs which are coming in the brain, and some part of the brain actually has to process that information, because you have to make sure that you weed out the things which are distractible if you want to actually focus on a task. So prefrontal cortex actually plays a very important role, that it helps to focus your thoughts, which enables people to pay attention and concentrate on the goals, Because just think about that, if you're in a restaurant having a conversation with the person next to you, and there's a lot of background noise, so this part of the brain actually can weed out some of those distractions and have you just focus on the person who's next to you that you're trying to pay attention. But if you find that person boring, maybe you don't want to listen to that person and you want to listen to the conversation at the next table, you can actually shift your attention to that. Ignore the thing, what the person is saying, and then start paying attention to that. So what I'm just trying to say is that, it's the prefrontal cortex which actually controls that. So depending on what your goal is, it's going to weed out the extraneous information and just help you focus on that goal. So older people actually have problem with that their system is not very fine-tuned, so they can easily get distracted. So the thing what we say to older individuals is that they really need to pay attention when if they are trying to learn information, and sometimes they may have to repeat that in order for them to retain information. So it's not that the older people actually lose their memory, it's just the way they process memory and the way actually the brain functions becomes different. So aging, losing memory is not a normal part of aging process. So what is some of the impact of aging on day-to-day ability? It does take longer for an older person to learn new things, because the speed of processing actually does go down. It's not that they can't learn new information, it just takes them longer to learn that. And then you've all heard about the senior moments, which even I experience, that sometimes I don't know the person's name, and then we know that there is decreased ability to attend to more than one memory task, that this distractibility is much more bothersome to older individuals. So that's why we have to, we can tell them some strategies, and we try to tell our older patients how to use those strategies to retain information a little bit better. So as I said, that it's not that they are forgetting, it's just the way that they learn information is much more different. So I think I didn't want to give you the litany of changes which occur in all the systems of the body. There are skin changes, the GI system has some changes. So I didn't want to really go through the entire, all the systems of the body, but just really try to focus on the things which are applicable to you, because I think the blood pressure regulation, how volume is regulated, temperature is regulated are really important when you're dealing with patients in the emergency room setting. So just to summarize our final thoughts, that aging is associated with reduced functional reserve and a compromised ability to cope with stressors. That's why when you see frail older people who already have compromise in their functional system, your function actually really tells about the clinical well-being of that person. I think we all know somebody who's 85 years old, they are robust, healthy, independent. We know that they are going to do much better as compared to somebody same age, frail, that they are dependent on their activities of daily living. So I think functional assessment actually becomes a lot more important in older individuals, because in my mind it's similar to what you see with blood pressure or temperature or pulse. You know that if the blood pressure is low, something is wrong, but we don't know what is wrong. So similarly, I think the functional status is a clinical marker of the well-being of that older individual. And most of the older individuals actually, if you're just thinking about aging, it really does not have that much impact on everyday life. However, the changes, these physiologic changes, become manifest at times of increased demand, that when they are under stress, they have infection, they are going for surgery, or they are hospitalized. That's the time that the older people actually start to have problems. That's why they are particularly vulnerable to develop confusion, which is a very common way of presentation of illness in older individuals, dizziness, syncope, when they are exposed to environmental, pharmacologic, and emotional stresses. And all these, if you think about geriatric syndromes, we talk about falls, dizziness, urinary incontinence, all these things are multifactorial. That is, some of it is related to age-related changes, and some of it is related to the medications we are prescribing with them or the comorbidities they are having. That's why I think when we have to do interventions, we also have to do multifactorial interventions in these patients to have better outcomes. So I hope that I try to convey that you have to look at older individuals in a little different way, and I'm sure that you do that, but just keeping in mind that the approach has to be individualized, because older individuals are very heterogeneous. I mean, you can have an 80 years old who is robust, maybe running marathons, and then you have somebody who's coming from the nursing home is much more compromised, and we really have to deal with them in very different way. Okay, thank you. Any questions?